Harold was 58 years old when his wife noticed something he had been brushing off for nearly 2 years. Every morning when he went to the bathroom, the water in the toilet had a faint, persistent foam to it. He had mentioned it to his doctor once. His doctor told him to drink more water. So Harold drank more water. The foam did not go away. 18 months later, at a routine physical that included a urine dipstick test, Harold was told his kidneys were functioning at 42% of their normal capacity. 42%. And he had not had a single symptom he would have called alarming. No pain, no blood in the urine, no dramatic sign that something was going catastrophically wrong inside his body. Just foam in the toilet that he had decided not to worry about. I am Dr. Sophia Ramirez, and Harold's story is not unusual. It is in fact the story of chronic kidney disease in the majority of the people who have it. The National Kidney Foundation estimates that approximately 90% of people with chronic kidney disease do not know they have it. 90%. Because the kidneys do not announce their decline with pain. They decline silently, gradually, and they send signals that most people and many doctors misattribute to aging, dehydration, or stress. Today we are going to go through 6 of those signals in precise detail. What each one looks like, what it means at a biological level, which studies have documented it, and exactly what to do when you recognize one in yourself or someone you love. These are the signs most often ignored until it is genuinely too late to reverse the damage, and after today, you will not ignore them. What you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. If you have kidney disease, high blood pressure, diabetes, or any condition affecting kidney function, please work with your doctor before making any changes to your routine. And if this is your first time on this channel, subscribe right now before we go any further, because the sign I am going to cover at number 6 is the one most likely to be sitting in your own medical records right now, completely unrecognized for what it is. It is the sign that kills the most people precisely because it looks like something else entirely. Subscribe and stay with me through all 6. Let's start with the sign Harold noticed. The one that was sitting right in front of him every morning and that he had every reason to dismiss. Foam in the urine. Not occasional bubbles that clear in a few seconds. Every toilet produces some bubbles when liquid hits liquid, and that is completely normal. What we are talking about is persistent, white, frothy foam that remains floating in the bowl for more than a minute after urination. Foam that looks like the head on a beer that will not settle, that is present consistently rather than occasionally, and that does not change when you drink more water. What causes it is something called proteinuria, protein in the urine. And to understand why that matters, you need a clear picture of what the kidney is supposed to do with protein. Your kidneys are filtration systems. Each kidney contains approximately 1 million microscopic filtering units called nephrons. Each nephron has a tiny bundle of capillaries called a glomerulus surrounded by a cup-like structure. Blood is pushed through these capillaries under pressure, and a filtration membrane keeps large molecules, including protein, inside the bloodstream while allowing water, salts, and waste products to pass through into the urine. Protein should never appear in significant quantities in your urine. The healthy kidney retains it. When protein begins appearing in urine, it means the filtration membrane has been damaged enough that it is no longer keeping protein inside. And the most common causes of that damage across all age groups, but especially in adults over 50, are sustained high blood pressure and poorly controlled blood sugar. Both conditions damage the glomerular capillaries over years, quietly, without pain, in ways that produce no sensation until a significant percentage of the filtration units have been compromised. Think of the filtration membrane like a fine mesh screen in a window. In perfect condition, it keeps everything above a certain size on the inside. Persistent high pressure strains the mesh. Over time, the openings enlarge. Eventually, things start passing through that were never supposed to. A study published in the American Journal of Kidney Diseases tracked adults over 50 with newly detected proteinuria and found that the majority had no awareness of any kidney problem before testing. The study also found that for every gram of protein appearing in urine per day, the risk of progression to end-stage kidney failure increased by approximately 50%. Foam in the toilet is a measurable clinical event with a specific biological cause and a documented relationship to outcome. It is not a cosmetic inconvenience. The practical step is specific. Ask your doctor for a urine albumin to creatinine ratio test, abbreviated UACR. This is not the same as a standard urine dipstick. Dipsticks frequently miss early proteinuria. The UACR is a far more sensitive measure and is the standard recommended by the Kidney Disease Improving Global Outcomes clinical guidelines. If you have diabetes, high blood pressure, or are over 60 and this test has not been ordered in the last 12 months, it belongs on your next lab order. Ask for it by name. The myth worth addressing directly here is the belief that if your kidney blood test, your creatinine or your GFR came back normal, your kidneys are fine. GFR can remain within the normal range while significant proteinuria is already present and damage is accumulating. The two tests measure different aspects of kidney function. A normal GFR alongside persistent proteinuria is still early kidney disease, and the window for intervention is still open. Both tests together give you the accurate picture. One alone does not. Stay with me, because the second sign is one that most people in this age group have already explained away as something else entirely, and that misattribution is costing years of preventable progression every single day. You notice it at the end of the day. Your shoes feel tighter than they did in the morning. You press your thumb into the skin just above your ankle, and the indentation holds for a few seconds before it slowly fills back in. Your rings are harder to get on and off than they used to be. Maybe your face looks slightly puffier in the morning before it settles throughout the day. The medical term is edema, and while edema has many causes, heart failure, venous insufficiency, certain medications, lymphatic problems, kidney-related edema has a specific mechanism that makes it identifiable once you know what to look for. Healthy kidneys regulate the body's fluid balance by filtering excess sodium and water out of the blood. When kidney function declines, this regulation becomes impaired. Sodium and water are retained rather than excreted. The excess fluid shifts out of the bloodstream and into the surrounding tissue, settling by gravity in the ankles and feet when you are upright, and in the face and eyes when you have been lying flat overnight. There is a second mechanism that is less well known but equally important. The kidneys, or more precisely, the liver responding to kidney stress, produce albumin, a protein that acts as a kind of internal pressure system inside your blood vessels. Albumin holds fluid in the vascular space where it belongs. When damaged kidneys lose albumin in the urine through proteinuria, the blood's oncotic pressure, its ability to hold onto its fluid, falls. The fluid leaks out of the vessels into the surrounding tissue. This produces a pattern of soft, non-painful, pitting swelling that worsens as the day progresses and partially improves after lying flat overnight. Think of your blood vessels as a garden hose with tiny holes along its length. Albumin is the internal pressure that keeps fluid moving forward rather than leaking through the holes. When albumin falls because the kidneys are losing it in the urine, the fluid pressure inside drops and leaking through the holes increases. The swelling in your ankles is that leaked fluid. A study published in the Clinical Journal of the American Society of Nephrology found that lower serum albumin levels, consistent with kidney-related protein loss, were independently associated with accelerated decline in kidney function over a 5-year period in adults over 55. The edema was not simply a symptom of the damage that had already occurred. It was a marker of an active process driving further deterioration. If you have new or worsening ankle swelling and have not had a kidney function panel, including both GFR and UACR, within the last year, that panel belongs at your next appointment. And if a doctor has attributed your ankle swelling solely to heart failure or venous insufficiency without evaluating kidney function as a contributing factor, that specific question deserves to be asked directly. Subscribe right now and stay with me, because the third sign affects every system of your body simultaneously and is almost universally attributed to something else. I have seen it diagnosed as depression, as thyroid disease, as burnout, and as simple aging in patients whose kidneys were already significantly compromised and whose red blood cell count had been quietly falling for over a year. This is the sign that erases the most time silently. You are sleeping 8 hours and waking up exhausted. The fatigue is not the tired from a busy day variety. It is a heaviness, a weight that is present when you open your eyes and still present when you sit down in the afternoon. And alongside it, a cognitive haziness, words that are harder to find, thoughts that feel slower, a difficulty concentrating that you might be quietly attributing to age. Kidney-related fatigue has a specific cause that is not shared by most of the conditions it gets confused with. Your kidneys produce a hormone called erythropoietin, abbreviated EPO. Erythropoietin signals the bone marrow to produce red blood cells. Red blood cells carry oxygen to every cell in your body. When kidney function declines, erythropoietin production falls. Bone marrow receives less signal. Fewer red blood cells are made. Less oxygen reaches the brain, the muscles, the organs. This condition is called renal anemia, and it does not produce the classic symptoms of iron deficiency anemia. It produces a pervasive sleep-resistant fatigue that does not respond to rest, and a cognitive slowness that comes not from the brain itself, but from the brain being undersupplied with oxygen. Think of it as a car engine running on progressively thinner air. The engine is intact, but it cannot produce the same output at altitude that it could at sea level because there is less oxygen available to fuel the combustion. Your brain and muscles are working, but without adequate red blood cells to deliver oxygen at the needed rate, they cannot perform at the level they did before. And because the decline is gradual, say on a slow drift rather than a sudden drop, most people simply adjust their expectations. They do less. They rest more. They accept it. A study published in the Journal of the American Society of Nephrology found that renal anemia was present in over 40% of patients with moderate kidney impairment, defined as GFR between 30 and 59, and that the majority of those patients had not been evaluated for anemia as part of their kidney care. The fatigue was being managed with reassurance while the underlying cause went unaddressed. The practical step is to ask your doctor specifically for a complete blood count alongside your kidney function panel and ask whether your hemoglobin level has been interpreted in the context of your kidney function. A hemoglobin that appears on the lower edge of normal may be clinically significant in someone with moderately reduced kidney function. Renal anemia is treatable, but only if it has been identified and connected correctly to its cause. Now let's talk about a sign that occurs at night, when most people are not paying attention, and that is being explained away millions of times a day in primary care offices around the world. You used to sleep through the night. Now you are up twice, sometimes 3 times to use the bathroom. And when you go, the urine is pale and dilute, thin, almost like water. You attribute it to drinking too much fluid in the evening. You try cutting back. It does not make a significant difference. Healthy kidneys concentrate urine during the overnight hours. They do this by reabsorbing water efficiently through the tubules, the long, thin tubes that follow the glomerulus in each nephron, in response to antidiuretic hormone, which rises naturally during sleep. The result is that in a healthy person, urine production slows at night, allowing 6 to 8 hours of uninterrupted sleep. When the tubules are damaged, this concentrating ability is one of the first functional losses to occur. The kidneys can no longer hold on to water during the night. Urine becomes dilute and is produced at a relatively constant rate around the clock. The result is nocturia, waking 2 or more times per night, accompanied by pale, very dilute urine, sometimes alongside more frequent daytime urination as well. A study published in the American Journal of Kidney Diseases found that nocturia occurring 2 or more times per night was significantly associated with reduced kidney function in adults over 50, independently of prostate size in men, bladder capacity, and fluid intake habits. The researchers recommended kidney function testing as part of the evaluation of persistent nocturia in this age group, a recommendation that is not yet standard practice in most primary care settings. If you are waking 2 or more times per night to urinate and this has persisted for more than a few weeks, kidney function belongs in the diagnostic workup alongside bladder and prostate evaluation. Let's move to the 5th sign, and this is the one that most surprises people when I explain its connection to the kidneys. Itching. Persistent, generalized itching, not localized to one patch of skin, not associated with a visible rash, that is worse at night, that moves around rather than staying in one place, and that does not respond to antihistamines or cortisone cream. Here is the biology. Your kidneys filter waste products from the blood continuously. One of those waste products is urea, a nitrogen-containing compound produced when the body metabolizes protein. In people with healthy kidney function, urea is excreted efficiently in urine and blood levels remain low. When kidney function declines, urea and other nitrogenous compounds, collectively called uremic toxins, accumulate in the bloodstream. These uremic toxins reach the skin through circulation. In the skin, they interact with immune cells called mast cells, causing them to release histamine and other inflammatory mediators. The result is pruritus and itching, driven not by a skin condition, but by the composition of the blood flowing through the skin. This is why standard antihistamines and topical treatments produce little relief. The itch is coming from inside, not from outside. Think of it this way. Your kidneys are the body's water treatment facility. When the facility is running at reduced capacity, waste that should be removed stays in circulation. That waste-containing blood flows through the skin, one of the body's largest organ systems, and the skin responds. The itch is the skin signaling that the fluid running through it contains compounds it cannot neutralize. A study published in the Journal of the American Academy of Dermatology found that uremic pruritus was present in a significant proportion of patients with moderate to advanced chronic kidney disease, and that in the majority of cases, the itching had been present for more than 1 year before the kidney diagnosis was formally made. The itch came first. The diagnosis came later, and the intervening year or more was time in which intervention was still possible. If you have persistent, generalized itching that is worse at night, that does not respond to moisturizers or antihistamines, and that has lasted more than a few weeks, kidney function belongs on your list of things to investigate alongside dermatological causes. Now, before I give you the sixth and final sign, I need you to understand something about it. The 5 signs we have covered, the foam, the swelling, the fatigue, the nighttime urination, the itching, these are signals the kidneys generate as they struggle. The 6th sign is different. It is both a cause and a consequence of kidney disease simultaneously. It drives damage while being driven by damage. It is the most common, the most dangerous, and the most frequently misunderstood. And it is the one most likely to be documented in your medical chart right now. Do not leave before hearing this one. Your blood pressure was controlled for years. One medication. The numbers were good. Then it started creeping upward. Your doctor added a second medication. The numbers improved but did not reach target. Now perhaps a third has been added or discussed and your blood pressure is still inconsistent or higher than it should be. And no one has said the word kidneys. This is the kidney hypertension feedback loop, and it is one of the most dangerous physiological cycles in cardiovascular medicine. Here is exactly how it works. High blood pressure damages the small blood vessels inside the kidney, specifically the glomerular capillaries, over years. That damage reduces the number of functional nephrons. Fewer nephrons mean reduced kidney function. Reduced kidney function impairs the kidney's ability to regulate blood pressure through a hormonal pathway called the renin-angiotensin-aldosterone system, which controls sodium retention and vascular resistance. A damaged kidney activates this system at a higher set point, causing blood pressure to rise further than it otherwise would. Higher blood pressure causes further glomerular damage. Further damage causes more inappropriate activation of the renin system. The cycle tightens with each revolution. The result is blood pressure that becomes progressively harder to control, not because the medications are wrong, not because the patient is non-compliant, but because the organ responsible for blood pressure regulation is itself driving the elevation from the inside. A study published in the New England Journal of Medicine examining adults with resistant hypertension, blood pressure remaining above target on 3 or more antihypertensive medications, found that a significant proportion had underlying chronic kidney disease that had either not been identified or was not being treated as a contributing factor to the blood pressure resistance. When kidney-directed interventions were incorporated into care, specifically optimized renin-angiotensin system blockade and dietary sodium restriction calibrated to kidney function, blood pressure control improved substantially in the majority of cases. The practical meaning is direct. If your blood pressure has become harder to control in the last 1 to 3 years, if it responded well to medication before and increasingly does not now, ask your doctor specifically whether kidney function has been evaluated as a driver of that resistance. Ask for both GFR and UACR. Ask whether your current antihypertensive regimen includes appropriate kidney protective agents. These are not aggressive questions. They are the precise questions the research says should be asked. And the myth to dismantle here is the one Harold held, and that costs lives every year. The belief that if your kidneys were failing, you would know, that there would be pain, that there would be a clear, unmistakable alarm. Harold did not have one. The majority of people losing kidney function do not have one. The kidney has no pain receptors in its filtration tissue. It can lose 60% of its function before standard blood tests begin to show significant abnormality. By the time obvious symptoms arrive, if they arrive, the window for meaningful preservation has often closed. Share this video right now with someone you love, the partner, the parent, the friend who has been on 2 or 3 blood pressure medications and still cannot get their numbers under control, or who has been brushing off ankle swelling and nighttime bathroom trips for longer than they should. Share it now before the close, then come back, because the next 2 minutes hold the most important and actionable part of everything we have covered today. Here is what to do in the next 48 hours based on what you just learned. Today, pull out your most recent lab results and look for 3 numbers specifically. Your eGFR, estimated glomerular filtration rate, your urine albumin to creatinine ratio, UACR, and your hemoglobin. If any one of these is missing from your labs in the last 12 months and you are over 50, write them down as specific requests for your next appointment. Do not wait for them to be ordered automatically. Ask for them by name. This week, track your body for 7 days. How many times per night you wake to urinate. Whether your urine contains foam that persists beyond 60 seconds. Whether your ankles are noticeably swollen by end of day. Whether your energy level is consistently lower than it was a year ago. Write it down. This is clinical information your doctor cannot access unless you report it. This week also, if you have been on blood pressure medication for more than 2 years and your numbers have become harder to reach target, schedule a conversation with your doctor specifically about kidney function as a contributing factor. Bring the question to the visit. Do not wait for it to come up on its own. At your next appointment, bring your tracking notes and your lab request list. Ask your doctor where your kidney function currently sits on the chronic kidney disease staging scale, stages 1 through 5. Ask what the trend has been over the last 2 to 3 years, not just what the most recent single value shows. Trend tells a story that a single data point cannot. You now know that the kidneys do not produce pain when they are in distress. They produce foam in the toilet, swollen ankles that pit under pressure, fatigue that sleep cannot fix, nighttime urination that cutback fluids do not stop, skin that itches without a rash, and blood pressure that climbs despite medication, and that every single one of those signals has a specific, traceable, biological mechanism behind it that can be identified, tracked, and in many cases significantly slowed when caught in time. Subscribe to this channel right now because the next video is going to cover 5 specific foods that published research consistently links to the fastest acceleration of kidney function decline. And 3 of them are foods that are commonly recommended for heart health, making them a trap that millions of adults over 50 are walking into at every meal. You need that information before your next grocery run. I will see you in the next one.